biologic tuberoplasty in patients with massive cuff tears. In order to understand that, I want you to pay attention to the acromial-humeral interval. This is what happens in a patient with massive cuff tears. When a deltoid fires, there's a dynamic pull of the humeral head, and which makes contact against the acromion. So it's honed in, and you can get a better look at it. And what ends up happening, you get bone-on-bone contact, which we know leads to pain. So essentially what the dermal allograft fixation to the greater tuberosity does is it prevents a bone-to-bone contact because it's acting as an interpositional tissue. Why do I do this, or when do I do this? In patients who have a preserved range of motion above 90 degrees, there should be Hamada 1s and 2s. They should have an intact or repairable upper border subscap, and no chondromalacia, no pseudoparalysis, and if they have an external rotation lag, that's when I do a lower trap transfer. So this is a technique. This is a patient with massive cuff tear. I use the burr on the reverse mode, so not to decorticate the tuberosity, just to remove the soft tissue, just to pepper the blood, get the bleeding. Then I measure the dimension of the tuberosity from the anterior to posterior direction. It's usually 25 millimeters, then medial to lateral, which is about 15 millimeters. Then the posterior anchor is placed first. This is a knotless anchor, which has a repair stitch and a loop stitch, which are retrieved through a 12 millimeter cannula. And if you're starting this out, you can use a cannula divider to keep the sutures separate. So you take the repair stitch and the loop stitch from one anchor and bring it out. Place the second anchor. This is exactly what you would do for a rotator cuff repair, the anchor placement. You take the repair stitch and the loop stitch from the other anchor and bring it out. And again, the cannula divider is keeping them separated. On the back table, the graft is prepared. You cut it to size, or they come in pre-cut sizes now. The medial margin is marked for orientation. Laterally, 2 luggage tag sutures are placed, so everything's done outside of the body. The graft is brought to the shoulder, placed on a towel,